All right, here's my little slice point. Welcome back, everyone. You're watching We Heart Therapy, the special series EFT Talk. I'm your host, Dr. Belle, licensed marriage and family therapist here in fabulous Las Vegas, Nevada, and I'm a certified EFT supervisor and therapist, and I help run the EFT community here we call it Southern Nevada EFT here in Las Vegas. And I am super excited to welcome our newly minted EFT trainer from Arizona. We have Rachel Thomas. She is amazing, and she is going to be joining us today to talk about attachment-based suicide assessment. Thank you, Rachel, so much for being with us, and congratulations on making EFT trainer.
Thank you so much for having me, and thank you for celebrating my newly moving into trainer status. So thank you.
That's so exciting. That's so exciting. Welcome, and we're so glad to have you. So let's talk about, so maybe if you would like to start us off, maybe we could talk about when we say attachment-based suicide assessment, how would that be different than a regular suicide assessment we might do?
Yeah, that's a great question. I think that there have been a lot of trainings, and we all probably had similar trainings in our graduate programs about risk assessment and safety assessment. And it was very much focused on um, access to means, the plan that the client might have about hurting themselves, taking their lives, and the intent, right? Plan, intent, and means. And very much focused on our liability. All very important, but I think it really doesn't address the humanity, the attachment longings, the attachment component of our work, and bringing in our attachment system, our client's attachment system, and really being aware of how that can show up as we're doing a suicide assessment or not, depending on our attachment system. So I think this attachment piece is such a critical part of leaning into these really hard conversations with our clients and really being honest about what's happening within us and our nervous system when we have a client who's at risk of suicide.
It sounds like kind of what I hear you saying, and correct me if I'm wrong, is that, kind of traditional suicide assessment is more about our liability, like really trying to check and see like how likely is this person, about to do something and, what level of intervention do we need to do immediately to do life saving interventions, get them to the hospital or whatever. And, which of course is important. But if assuming that the client is not in immediate danger and we're not needing to hospitalize them, I think doing the attachment-based suicide assessment really gives a lot more meaningful context to what's going into this feeling. And I wonder if it might be important to clarify, you know, like, how would people, when we're doing the attachment intervention, sort of like differentiate between somebody who struggles with the thoughts and, maybe talk about kind of emotions go in with that place versus someone who is an immediate, like, we need to send them to the hospital right now?
Yeah, I mean, that's a great question. I think that there's a lot that goes into the assessment. It's not a one and done, it is an ongoing process, and it's a continuum of risk that we are assessing. And if we're really working to connect with our clients, it's very common for people to have points in their life where they're feeling tremendous amount of pain and suffering, to the point where they would like to not be on this planet anymore. And there's a very big difference between a fantasy or a hope of dying, and a real plan and a real focus of taking someone's life. And so I think as clinicians, we don't always know how to ask those questions. We get scared about asking those questions, or we avoid it because of our own attachment systems, and that liability risk of, what am I like? I am responsible for this client, but ultimately we can't predict behavior as clinicians, and so it is important that most therapists have fears around liability around suicide of a client. And so we need to be able to talk about that so that we can talk about how that fear shows up in the room and what we can do to lean in and really connect with our clients and have the conversations so that we can then have the assessment about where they're at on that continuum of risk and then determine what the course is from there.
Yeah. What kind of fears do you find come up with clinicians when they're a little trepidatious about bringing up suicide or suicidal thoughts for
Well,
their
there's a common fear that people have of like, if I like, they're going to make our client, their client more suicidal, which is the truth. The research shows that there's no correlation with that at all. But that's kind of one that we've seen, and there's been research around. There's also a fear around how do I ask in a way that isn't, you know, maybe too direct or harsh, or and I ask in a way that's very compassionate and kind. I don't know the languaging, so I just don't ask at all. Or some of the fear is, I mean, a lot of the fear is the responsibility of like, how will I know what to do with it? Like, what if they do say yes? Then what? And then what? And then what? And so there's both. There's avoidance strategies around the fear where they end up kind of pulling away and maybe not leaning into the conversation, the therapist. But there's also anxious attachment strategies where maybe they come in real direct and not as much empathy and not as much compassion, where they come in a way of like, I need to know, do you have a plan? Do you have an intent? Do you have means? And it can be really jolting to all of a sudden your therapist come at you. And both ways, like we need to be able to talk about and really be able to explore, how do we show up when a client is at risk?
almost like intimidating if we come in too strong, too hard. And it's like, well, if I
Exactly.
did have those feelings, I'm certainly
I'm
not
not
going
going
to tell
to
you
tell you.
about it.
Exactly, exactly. It can be overwhelming. It also can be, concerning to the clinician, to the client of, what is my therapist going to do if I'm honest about that? And so there's just a lot of dynamics going on. There's a lot of dynamics. So we need to be able to manage all of that
Mm,
and really help the client find tools and strategies when they're in that space so that they don't feel alone. Because again, from a detachment stance, we know that humans crave connection. And a big risk in suicidality is a perceived sense of isolation, a perceived sense of social disconnection. And we are one of those attachment systems. We are one of those people that care about our clients and that we want them to know we care about them. We're concerned about them. We want them to stay on this planet and we want to make sure that they're safe. And so we want to be able to have the conversation with them, the honest conversation, just like we do in EFT.
yeah, I really like that. And it kind of brings up for me some of the things I hear my colleagues talk about where, they might deal with a demographic where they're faced more often with clients that struggle with suicidal ideation. And, sort of that sense they hang on to that hope that maybe even I, as the therapist, can be, the first ray of hope in their life. And so our therapeutic relationship, through the understanding and compassion that I provide them, can be a part of what keeps them hanging on as we work through this. But then some of them kind of struggle with feeling like they're taking on a lot of pressure. And then, sometimes clients do complete suicide and it feels so hard. Even for the therapist, we can end up looking inward and like, is there something else I should have done or should have known or, you know,
Yeah. Again, this is something I want to be able to talk about. 1 in 3 clinicians, think about that. 1 in 3 clinicians have a client that dies by suicide. And we don't really open space to talk about that and really normalize that it can happen and it does happen. And there can be shame that shows up. There can be tremendous amounts of responsibility and grief and pain. And we want to connect with each other and collaborate in these conversations so that we as clinicians don't feel alone in it and in that pressure and responsibility. Because again, we cannot predict behavior. And our responsibility is uh, an obligation to assess and manage risk and to work with our clients around strategies to help them feel a sense of safety so that is documented and that is covered. But ultimately a client can choose not to tell us, and a client can make the impulsive suicide act despite any and all of our efforts. And so I want to create a culture of therapists where we can be able to talk about that and navigate that and support each other without the shame and the pain that they're already most likely feeling.
Yeah, yeah. I just love that there's so much empathy and, even when we do all of our checks and check-ins and we're there, you know, sometimes humans still make choices that, you know, aren't always known to us at the time, no matter how much we do our due diligence. And it is painful because we do care. We're professional caregivers, life matters to us. And but learning how to still talk about that and be real, in a way that we can have these conversations in the room is what you're saying. And it is important to be able to have these conversations. I'll say probably one of the weirdest things that ever happened to me as a clinician, I had someone I was supervising and their client had texted them for an appointment and said they were having suicidal thoughts. And then apparently the person went and took a nap and my clinician couldn't reach them. And they knew like, hey, if I can't reach you, if I can't reach your emergency contact, I gotta call emergency services. So,
Yeah.
they called me and I said, well, we can't take any chances. We got to know our protocols. So, non-emergency police knocked on the door. Of course, the client wakes up and finally gets back with a therapist and was like, I'm sorry, I realized you couldn't
Yeah.
reach me. I shouldn't have like said that and then just dropped off, so
Yeah.
to deal with that. And it was a lot of discussion about, again, how to have these conversations with the clients and um, but also having ideation doesn't necessarily mean that there's an intention. I love what you said earlier was sometimes it's just people find themselves in such a hopeless, despairing, isolated place where they're kind of questioning their value and their existence. Like, if I don't really matter, what am I really doing here? And it's just more of like a lamenting, or maybe like, if something happens to me, okay, whatever, but they're not necessarily proactively setting out with a plan to, end their life. So,
Right. But passive suicidality also needs to be assessed if they don't wear their seatbelts or they're doing high risk behaviors because they would
mhm.
be okay if they died, but they're not intentionally trying to die. We still need to be able to talk about that and assess. And Joiner's interpersonal theory of suicide talks about exactly what you're talking about, Annabelle, which is the sense, the isolation, the sense of social disconnection. That's that perceived subjective feeling of isolation, and the sense of hopelessness and the burden that I'm put, like it would be better for people if I wasn't here. Is to, again, perceived subjective, but that feeling, those two combined, are really high in terms of our risk factors. And our job, I think sometimes as clinicians, we also care so much that we can take on even more, and we become the person who is, in response every time a client is expressing suicidality. And part of our treatment goals needs to be to help this client have more sense of connection with others so that the responsibility isn't just on one clinician. It's too much, and it's not healthy either. It's not ethically appropriate. It's not healthy, and it also, again, is in response to the clinic. Usually, not always, but usually in response to the clinician's attachment systems.
Hmm. I love what you said. That was a really good point about passive suicidal ideation, like, doing some assessment there. Like, maybe they are in a place where they're just like, well, something happens to me, I don't really care. Again, doesn't necessarily mean they might actually be doing things that will prevent that from happening. But I love that we need to also be able to check Are they are they actively not preventing their death, which would be different than I'm just thinking about it, and if it accidentally happened is one thing, but if I'm not preventing, putting myself in harm's way so that I sort of am tempting fate, it's like an active passivity. you know
Exactly. Exactly. And so that person, we wouldn't go straight to hospitalization for that client, but we would absolutely discuss ways for that moments when they feel better. We would explore a whole bunch of different ways that the client can engage in their life in a way that keeps them safe. So that would be part of our documentation and our treatment and our attachment. Again, our attachment connection with the client of, hey, these behaviors worry me. I want to make sure, let's talk about it.
Yeah. So, where would therapists start when they're wanting to use the attachment frame for their suicide assessment? Where would they start?
Oh, that's a great question. Well, as I was hearing you, where would they start in the assessment? I would say it's before you're even sitting down with the client. What happens for you internally, even as you're listening to this conversation with me and Anabelle? Like, what happens for you as you think about client suicidality, the risk, and what is your own history? A lot of us have experience of suicide, of people we know, of clients, of experiences that we've had in our world around suicide. And so, really exploring that and doing a little deep dive of self of the therapist around how do I think I show up around this conversation with my clients? Am I leaning in and having the conversation or am I avoiding? I think that would be where I would start, and bringing it to supervision or consultation or talking to a peer and really being honest about that with yourself would probably be where I would start. And then in terms of the actual assessment with the client, I would just say it's really common when somebody's hurting to have thoughts of wanting to relieve the pain at all costs. And so I just want to check in with you as a client. I just want to check in with you around, is that something that you're thinking about? It would make sense to me, right? I want to validate that. It would make sense to me that you would be having those thoughts. And so I am showing them that I can have this conversation with you.
Mm. And I love what you're saying. You're validating the thought and the emotion, not necessarily the behavior. Because I can hear, like, you know, some therapists like, wait, I'm so afraid that if I say that, somehow it's like saying it's okay for you to do this, or it makes sense,
Exactly.
you'd want to do this, and that's going to make them more likely to want to do that. But that's not what the research says.
No, and that's exactly why people don't ask the question, is because it almost sounds like I'm saying, yeah, I get it. You should do it, which is
Yeah,
not all, oh my God, that's not at all what we're saying.
right.
But I can't tell you how many clients have shared the experience of taking a deep breath and being like, yeah, it does get dark sometimes, usually in the middle of the night, usually when I'm completely alone and down and out. That's when I start to have those thoughts. And my job is then to say, and I don't want you to feel alone in that, but it's really important to me that you never reach a point where you're going to actually act on those thoughts. And so, can we have more conversation? Is that okay if we spend some time here? And then we really talk about it from there.
It's really beautifully said. And it really reminds me of just in general what we do as therapists and, in EFT.
Exactly.
And I hear a lot of therapists say this even outside of, talking about suicidal ideation, like I'm afraid to bring up my client's hurt or pain. Somehow I'm going to make it worse by talking about it. It's like they're already feeling it. That's why they're in therapy. And the problem is they're alone in it. And if we don't talk about it, we keep them alone in that place. And it's
Exactly.
so validating, like validation in and of itself, being seen and acknowledged for your experience, like having the context and the emotion that we've come to legitimized is an intervention in and of itself that's very therapeutic, because often when we find ourselves in pain and even the highest degree of pain, it's like one of the things is we feel like nobody really sees us in this place, so for you as a therapist to be seeing them in this place, it's like, it's the first step towards not being isolated.
Exactly, exactly. And if I'm really able to share my heart with my client, that I am right there with them, and that this is normal, that having worked at hospice, and working with people in that raw pain and grief of the loss of a loved one, like that pain is so severe for some that does there is this like desire to be out of the pain. And so I really normalize that and just let them know, like, it makes sense, like you are not alone. People who have walked through losses like yours have also expressed, wanting the pain to go away. And again, it's not that they sometimes clients or clinicians will ask, do you ever have thoughts of hurting yourself? Most clients don't want to hurt themselves. They actually want to relieve the pain. They want to relieve pain and suffering. And so if you say, do you have thoughts of hurting yourself? That's not usually their go-to. It's like, I just want my pain to go away. I just want to stop this awful suffering. Does that make sense? The difference?
It's almost like more appropriately would be asking about the degree or an intensity of their pain and the desire to relieve the pain as opposed to, do you want to hurt yourself?
Sleep.
Yeah.
And we don't assume that the pain is the same all the time. So when are there moments when it's not so bad? When are
Mm.
there moments when you actually aren't in that severe pain that you go to thinking about thoughts of taking your life, right? So because there are moments where maybe it's not, and we want to highlight those moments more and more. So
Right.
yeah,
Widen windows of light
right,
that can help the darkness. And,
right.
I kind of, and everybody knows I've said this, if you guys if this your first time on my podcast, go back and see my episode about ADHD. So my ADHD brain sees things in metaphors and pictures and, you know constantly kind of these comparisons, and I'm thinking of the overlap with couples therapy where they get to this place of hopelessness where there's like an assessment question where we're like, do you want out of the pain or out of the relationship? And when people are at their most despairing, like they'll all say, I really want out of the pain, but because I feel so lost and hopeless, I don't know how to get out of the pain without getting out of the relationship. And it's like kind of similar to where people can find themselves, where they start to contemplate no longer being on this earth. It's like, I don't know how to get out of the pain without getting out of life altogether, you
Right.
know?
Right. And that's a great example, because we don't want to, just like in EFT, we don't want to cheerlead somebody out of their pain. We don't want to, it's going to be okay. It's not going to, we don't do that with our clients in EFT of like, don't, we actually walk into that with our clients. And this is no different than that. We want to hold hope, just like we do with our couples, just like we do with our clients. We hold hope because we have the map, we believe in the model, we know how to help couples navigate these disconnects. When we're working with a client with suicidality, we have hope, and we can hold out that hope that it will change. It won't stay in this level of pain, but I'm not going to try and talk them out of their pain and say, it's going to be okay. Just hang in there. You're going to be fine. Like, don't worry about it. We don't do that, right? It's so dismissive.
It's like, I'm not going to paint over their pain with
Oh,
rainbows and glitter and say, oh,
right.
silver lining. It feels so misattuned.
Yeah. Lisa Palmer Olson calls it fairy dusting. We don't fairy dust.
Yes, yes. I say something very similar to my couples and my clients in my office. And, it's like, and, I think the importance of kind of parsing that out, wanting out of the pain versus wanting out of the relationship or wanting out of life. I just run out of, I'm hopeless and I don't know how to achieve that, can be a helpful distinction, because then we know like the real thing is that they don't actually want out of this, out of life or out of the relationship, but the pain is just so hard and they've run out of options or solutions. And so we can walk into that pain with them. And again, just like in EFT and attachments, we've learned in the emotion, the answer for the pain is in the pain, the solution is in the pain, right? And there's information available in that emotion that we don't have access to outside of that emotion. It's like a vault that gets locked. I call it my corny Harry Potter metaphor, the Chamber of Secrets becomes unlocked. When we can go into that emotion, we enter the Chamber of Secrets, and there's information there we don't otherwise know. We don't go to the pain because we're masochistic or sadistic and we're emotionally cutting with the client, and again, like a lot of therapists have that idea. If I walk into your pain, somehow it's like saying it's going to make you feel it worse or more. Or I often have this with, I hear this with both therapists and clients, when the partner is suffering or a friend is suffering, and they say, well, I don't want them to feel that way. And that's certainly understandable. The fact that they're hurting matters and you'd like them to feel good about themselves, safe, loved. But when we tell someone, I don't want you to feel that way, it just kind of skips over and bypasses the reality of, I am feeling that way, and I'm going to feel it that way whether you like it or not, you know? So
And it
instead of,
shuts down the conversation. So
yeah.
what it does, it shuts down the conversation because the client will then feel like you can't really handle where I really am. And so can potentially just shut us down.
And I think this might be important. It's like to step into that and acknowledge, I understand that you're feeling this way. I know some might say it feels like it's saying it's okay for you to feel that way. What if it is okay for them to feel that way, right? We're talking about emotion versus action tendency, right? Completing suicide would be an action tendency, right? The emotion would be the thing where all the pain lives, the target of that intervention. And so again, we're not saying this is the solution is to end your life or, take this action or that action. It's your pain is understandable. You're suffering and it's okay to have pain, right?
And if we're really being honest, that is one option, but there are also 1,000 other options. And so my job is to help you see all those other options because what I do know is that feelings do change. And what we know in EFT is if we lean into the pain and we lean into the fear and we lean into those really vulnerable feelings, that they go down into that place and then they move out of it, right? And so, and usually, not always, but usually there's some relief on the other side of it, right? So, what I know is that the pain is not permanent, it is something we can move through. And my role is to help you find a whole bunch of other strategies than that one that you think is the only door out.
Yeah, that's so important because that's what I think or what I hear people kind of talk about is that if I somehow legitimize your hurt or your pain or your suffering, that you're going to get stuck there and never move out. And I sort of think, with empathy, again, it's that walking a mile in someone else's shoes when it's you and somebody says, I understand that you feel that way. And, it makes a whole lot of sense. All of a sudden, if you notice in your own nervous system, it's like, "Whew, that feels kind of nice. Like, because I'm getting seen and understood and connected to, which is usually the missing component. That's where people get stuck. And I think, what reminds me is this is where that tendency to want to problem solve, right? Is that, oh, the fact that you're hurting is the problem and we need to solve the problem of hurting rather than you're a person to be loved. And the real problem is that you found yourself alone and feeling unworthy, that you don't matter, that your existence doesn't matter. Maybe you have shame, maybe you have this. And the antidote to that is love and connection, acceptance, all those things. So it's like we sort of decide their pain is the problem rather than information about a problem. And then we treat people as a problem to be solved rather than a person to be loved.
I love that. And I go back to the beginning of our conversation about our attachment systems. And in EFT, we talk a lot about attunement. And if our nervous systems are activated in either way, hypo or hyper arousal, we may not be as attuned. So when we are empathetic and compassionate to our clients, if we're not aware of our own system and how what's happening for us around the risk of suicidality, and we try to be empathetic and compassionate, it may come out in a way unintentionally that could be really misattuned. And then the client won't have the experience of what you're talking about, where they go, oh, yeah, thank you. You know, that it just helps me not feel so alone, right? If we're not really clear of how we're showing up.
Mm-hmm. Yeah. The solution to isolation is connection, not being alone, right? Doesn't mean you're both going to get stuck there. It's actually you walk into the dark, link arms with them, and together the light starts to turn on, and suddenly we're both not in a dark place anymore, right?
And
Just
one of the reasons I'm so passionate about this topic is I want us to be able to talk about it more and more and more so that it doesn't feel so anxiety provoking. It probably always will, as it should. We're dealing with humans, we're dealing with people's lives, we're dealing with our responsibility as clinicians. But if we as clinicians can keep having these conversations and really being honest about what it's like to sit in our chair when we have a client who's at risk of suicide, the more unisolated we are, the more our nervous system calms down, the more we have support. So we have places to go to consult and get support as needed. The more likely we're going to show up with our hearts open, and we're going to be able to use our brains, to use our intellectual skills to be able to support a client in this place. Right. So it gets me very excited to continue to have these conversations. It's why I'm so very grateful that you invited me. So thank you.
Yeah, thank you. Yeah, I love what you're saying. Again, just reminding folks that attachment, connection, emotion, all in our nervous system. And if we, as the therapist, have alarm bells going off around talking about this subject, then our nervous system is going to go to into fight or flight. We don't have access to our prefrontal
Exactly.
cortex, that other vault, where we could come up with good solutions, work together. We won't have access to that. So helping ourselves become comfortable with the uncomfortable, leaning in so our nervous system doesn't go into full red alert. And then we have all systems stay online and we can be there. And really, the biggest things I hear you saying is talking about our clients' pain, their suicidal ideation, their hopelessness. None of that is going to make them more suicidal or more likely to take their life or increase their pain. In fact, it's actually the opposite effect.
Right. Right.
So, everyone take a deep breath. It's okay to talk about it, and we must, because if we don't, we just increase the isolation. We do more of what is already happening, and we
Exactly.
don't want to do that.
Exactly.
Yeah. And so the attachment assessment helps us. I love, to me, attachment is the science about how we human, right? It informs how we interpret ourselves and others in the experiences we have as we move through the world day to day, right? And that informs how we feel, the emotions and the behaviors that get attached to those, aka our coping strategies. All of those work together. And attachment really helps us get a more holistic picture. We don't just isolate symptoms. In fact, we see the symptoms as information about the problem or about the system and how the system might work. And our goal in EFT is to not just intervene on symptoms, but to
Right.
change the system itself.
Right. Well said.
A lot of S words.
Right. Right. Well said.
Now, can we talk about another aspect of suicide that comes up that can also be uncomfortable? And this is almost on the flip side, where we may have clients, and I think this comes up a lot in couples therapy, where one partner may throw out, I'm going to kill myself in during fights or struggles, and maybe they have had attempts before. And so that leaves one partner, it becomes like a trump card so that one partner can never talk about what's real or their own hurt. And they always feel like they're at the mercy, kind of tiptoeing of is anytime, things go off the rails or I'm upset or things go wrong, my partner's life is really literally in my hands. Like, What do we do in those kinds of situations?
Yeah, I mean, unfortunately, I think when the relationship is in such distress, um, we will often hear couples will threaten to leave or divorce, right? And when we assess, we learn that it's not that they really want to leave their partner or divorce, but it's part of their cycle and their dynamic. And so, in this lens around suicidality, we don't think that a client is being manipulative or that a client is not being true. We actually hear that as a protest of the pain and the fear of whatever is happening in distress in the relationship. We always take it seriously and we will always manage it, but we need to assess, how to get this person support so that when they reach that level of distress in the relationship that they don't move to that action tendency, because what they're really saying is the pain and the fear of potentially losing you, or the pain and the fear of not being able to reach you in this moment takes me to a place where I don't even know if I can live, right? But that's not necessarily, and so therefore I'm suicidal. And what it can do is, after time, make the other partner either not take it as seriously, or the other partner might end up starting to avoid engaging because they don't want it to reach that point. And so it really feeds the systemic problems in the dynamic. And but we always, as clinicians, want to take it seriously, and we always want to assess further and lean in to those conversations, whether we need to meet with them alone, highly recommending individual support to help them manage that fear and that pain so that they can come to the couple session and really be able to share about what happens to them in those moments when they move to say that the level of, pain is so severe that if you do blank, I'm going to take my life, I'm going to kill myself, right? That shows that there's something here that we need to explore further. Like you said earlier, it's information, but we always take it seriously and we assess further.
Yeah, and what I also hear is I don't hear that if those kinds of things get thrown out, that suddenly we stop couples therapy altogether, just send the one to individual therapy. I know I've heard some back and forth conversations with clinicians about, if you have one partner who becomes suicidal, does that mean that you can't do couples therapy and they should just be an individual therapy? What would you say to that?
Yeah, I mean, there's a lot around that we haven't talked around clinical depression and suicidality, but it doesn't warrant not doing. There's my double negative. It doesn't warrant stopping couples therapy because a client is saying that they're reaching a place where they're feeling suicidal, or if it is part of their cycle that they end up saying that. We do need to assess further. But again, a risk factor is subjective feelings of loneliness and isolation and social disconnection. So we would not support more isolation or disconnection. We actually would continue to support ways of helping this couple find each other. And what we know is that the other partner, if it is like a clinical depression, or that the other partner is impacted by that as well. And we want to be able to have those conversations just like we would anything, couples where one has ADHD, or couples where one has, like, any dynamic we would plug in, even medical conditions. I have a client where one suffers from, a couple that I see, one partner suffers from severe migraines. They're debilitating, and we have externalized migraine as part of their dynamic. We would do similar around the depression, because the depression impacts both of them.
Yeah, so I love what you're saying is even if, there is a concern or a dynamic of suicidal ideation within the coupleship, that we wouldn't support, isolating them and just working with the one individually only. Would be good to sign a release to collaborate between the two.
100%.
That way it can be mutually supportive. But all the science points to, again, more connection, the better it's going to be, the better together. And, they're, like you said, they're going to be dealing with this at home anyway. And if we don't meet them in that place and find a way to talk about it with them and help them talk about it, then we're leaving them again alone in the darkness together and not knowing how to have these conversations or how to comfort or show up for each other in a way that actually promotes that healing and connection.
Exactly. Yeah, exactly.
Yeah. So, um, this is really good, really good. I think the important parts are just, and you gave a lot of good examples of language, and I hope folks maybe you'll rewind and write down Rachel's beautifully worded statements. And I think first and foremost, because there's so much we could say about this, and Rachel teaches workshops on this, so I hope that you guys will look her up and have her teach a workshop on attachment-based suicide assessment in your area. But really the key points are that we have to be able to talk about it, and not talking about it or talking about it isn't going to make it worse or make them more likely to do it. It's actually talking about it, meeting them in that place is more likely to promote connection and healing and help make the situation better. It's the greatest chance.
The relational component, we're not checking boxes of plan, intent, and means. And we're not checking boxes of I completed my CEU training. We're actually leaning into the discomfort
Mm.
that this topic brings up and being able to talk about that and the relationship component between clinicians, but also between clinician and client, of course. So the attachment, the relationship is so important as we're having these really hard conversations. They're still
Yeah.
hard for me. It's not an easy topic. I had a client last week who told me that they reached for a bottle of pills when they were in a really bad place. And
Mm.
I actually felt a little surprised. I didn't know that that was, it's a newer client, and I didn't know that that was something that it got that bad, that it reached that. So, I've been doing this a long time. I have an expertise in this area, and I still had like an uh-oh moment of like, wait. And so what I did is I put both feet on the ground. I took a sip of water. I leaned forward and I took a breath, and then I just stayed really curious and stayed with him and just really honored that he shared it with me, that this was huge for him to feel like he could tell me. He's
Mhm.
in the field, so he knows even bringing it up is, means something. So,
Yeah. Yeah, because if we're uncomfortable talking about it, the client won't feel comfortable talking about it with us, and then we won't actually get to lean in. And just
right.
because a client does struggle with thoughts doesn't mean that they actually have the desire or intention to act on it. So they just need someone to step into the darkness to see it for what it is and meet them in that place and help them find their way through. And I think that's really like the hallmark of what you're saying is that we have to be able to lean in and be there with them. And, even if you don't work with a demographic where this is more of a common dynamic than others, it doesn't mean it won't ever show up, and I think the more that we can lean into it, talk about it, the more equipped we are to help and, get training to help us be comfortable in those spaces. Because a lot of clients will find themselves in dark places where they feel despair and, you know, it's in that despair where you're feeling like your life doesn't matter, that your existence doesn't matter. That's where those kinds of things start to take root. Doesn't mean that I want to feel that way or that I intend to act on it, but I do need someone to be able to step into reality with me and not tell me I'm ridiculous for feeling the way that I feel or I'm unreasonable, but to understand, which is more likely for me to trust them and to help me find a way out of the darkness.
Exactly. Yeah. Well said, my friend.
Uh, well, Rachel, can you tell everyone how they can find you if they'd like to book you for a consult or maybe a workshop to teach about suicidal assessment through the attachment lens?
Absolutely. You can always go to my website, therapywithheart.com, all spelled out, no spaces, therapywithheart.com. And you can also email me, RACHEL at therapywithheart.com. And I'm happy to talk about what maybe your requirements are for training on this topic in your area, and happy to support you in any way I can.
Perfect. And she's a tremendous EFT trainer. So if you guys want her to come and do an externship or course skills, or you want to go to Arizona and attend, there's the Arizona EFT community. And Rachel's just absolutely fantastic. So I hope you guys will look her up and contact her. And it's funny because your practice is therapy with heart, and I'm like,
I
it's kind of
know.
like we heart therapy backwards.
I know. I was thinking the same thing. I know. I love it. I love it. We're connected.
That's awesome. Well, Rachel, thank you so, so much for being with us today and just sharing the benefit of your wisdom. And I know there's so much more that we can say about this. However, we have limited time. It's just a small podcast and not a training workshop. So I do hope that if you're listening to this, that you found some of this information eye-opening and helpful, at least encouraging for you to feel like you can step into that place and with more comfort and yeah, really be able to step in that place with your clients. And I thank you to all of our subscribers and our viewers. You guys have made this channel a success, and thanks for sending me your ideas. Keep it coming, guys. And if you haven't hit subscribe already, make sure you do so because more videos are on the way.